Good afternoon, everyone. We are live. We can start the session.
Okay. Okay, hi and welcome everybody. So all those of all you've joined on Zoom as well as the YouTube channels, a very good afternoon to all. So today we have really great esteemed members here on this particular webinar with us. We have Dr. Nilima Bedekar ma'am and we have Dr. Ambrish Akre sir. So I'll just brief you a little about both of them. They are well-known personalities, but I would like to add on a little. So about Dr. Ambrish Akre, he's the founder and CEO at PhysioEd, BPT, MPT, CMP, COMT Australia, MIAB. Sir has a master's degree in musculoskeletal and sports physiotherapy from the prestigious KLE's JNMC Belgaum under RGUHS, Bangalore. Sir is certified. Sir is a certified Mulligan Concept practitioner from Mulligan Concept. He's internationally certified COMT in spinal and peripheral joint mobilization from the prestigious Melbourne University, Australia. He's a certified McConnell Concept practitioner and has mastered the concept under Jenny McConnell herself. He's a certified kinesiotaping practitioner from Kinesio University. Sir is an internationally certified ergonomic practitioner from EPM International Ergonomic School. He has conducted over thousands of ergonomic training sessions in leading software, electronic, and mechanical companies in Pune. So Sir has an experience of about 16 years, which includes 10 years of academic teaching experience as well. He was a lecturer at various colleges in Pune. Also, I would like to mention that currently he's in Sydney, Australia, and he's associated with, just a second. So he continues to upgrade his skills by doing continuous hands-on virtual education through multiple universities and bodies. Australia, namely University of Melbourne, University of Tasmania, Lung Foundation, Australia. Also, currently, like Sir is, I and Sir both, we are working on PhysioEd, which is a global education platform. My name is Dr. Harshita Mehrotra. I'm based in Delhi. So I am certified with DCPT, IAP, and Poru, Ireland. Currently, I am practicing in Delhi as a senior consultant at a few hospitals and visiting at certain others. So our aim is basically to connect physiotherapists globally and have a uniformity in good level of content and education worldwide. So I think now from us moving on to the VIP of this particular webinar, that is not Dr. Nilima ma'am. I just introduce her for our audience. Ma'am is a BSc physiotherapist from GMC Nagpur, MSc UK, PhD Pune University, professor and HOD MSK Sancheti College of Physiotherapy. She's also a PG and PhD guide, former academic council member and chairman undergraduate BUS at MUHS Nashik, expertise in women's health, yoga, electrotherapy, and she also has over 30 publications in national and international journals. So I think we've just summed up. These two people have a lot of more things to be talked about, but to keep it short and move to the topic, I think we'll move to ma'am and sir.
Yeah, thank you so much, Harshita, for the introduction. So yeah, those were very kind words for everyone here. Firstly, I would thank Nilima ma'am and Sancheti College, including Physio TV and Ortho TV, to give us the opportunity to have this session along with PhysioEd. It's a big honor for a small platform like us. Like we have just started 6 months back, and the minute ma'am spoke about this, we were more than keen to have this session happening. So I won't waste more time because it's going to be a flow of knowledge, of thoughts from Nilima ma'am. And as we are all aware, the topic which you're talking about is overview of research methods and study designs. It's a very big and vast topic, as we are all aware, but I'm sure ma'am has put it in a very short and a sweet way for better understanding for each one of us. So without wasting any further time, I would hand it over to Nilima ma'am.
Thank you so much, Dr. Harshita. and Dr. Amresh for inviting me for this topic, which we all need to do. So I thought it will be an overview. I'll just start sharing the screen because it's only 1 hour. That's why I'm saying overview of what we are going to say today. So I'll just start the slide. Right. Yeah. Is it visible, the slides?
Yes.
Yes, ma'am.
Yeah.
So today, it gives me a proud privilege to present an overview on the research methods and the study designs, which we all need as a physiotherapist. So what we will be discussing that which research methods are available, when to choose them, and the two methods which are there are different study designs which will help guide, and we can continue our research finding an appropriate way. So just a brief introduction before that who should be doing research. So I believe normally research is undertaken by undergraduate students for completion of the project work, by postgraduate students for their dissertation, and the PhDs for their thesis. So that's where the biggest chunk of research comes from in India. But as a clinician and academician, we need to have a substantial contribution towards it, because then we can have it in collaboration also. So doing a bigger research projects in collaboration is also the need. But it's the clinicians, because after all, we are doing this for the patients. So we want the best of the treatment for given to the patients. So whenever we do the best of the teaching, ultimately we are there for serving the people. Hence, each and every one of us as a professional, I feel have a responsibility towards research, because it's indeed very, very valuable to us. And we'll all understand that if we have one publication of a good research, then our name will be there forever. So if anybody types in and we are there, right? So you will understand when my first publication came, it came very late. So don't waste your time. Whatever the study we are doing should be published. So that's very important from the point where patients are also getting recruited. We tell them that we are going to disseminate these results which will help and guide. So for doing this, that's a high value. We must choose the right path. So whenever we are thinking about doing a PG, take an institution or college which promotes research in a big way. Or if we are going to take up a job, see that there is an opportunity for doing research, because that conducive atmosphere also helps. We need a team. So choosing this right path is very important. Here, I would like to slightly add to something, one more thing, along with research. If we are clinicians and we follow certain protocols, we can do an audit for our practice. It's very important. There is a thin line between a research and an audit, but an audit also can be published. For example, when I was working at Liverpool Women's Hospital, we used to give them the abdominal beds for low back pain women who during their pregnancy of various sorts. So it was a tubic grip support, or it was an abdominal binder with extra elasticated straps to support the SI joints, or a SI belt. So it was given as a practice beyond certain problems. So and all of it is given free of cost. So we need to identify whether it is going to help them, or we give them, they keep it, use it, how effective it is. So we need to audit ourselves and put forth about our practice, how it is helping our patients. So even if we start with an audit as a clinician, that will lead to a research question to us, and then we can formulate a research project in a bigger way. So we can start with doing an audit. We can publish an audit also. Journals do take audits, and it helps the administrators also where to fund, how to fund, what we are doing, as is it helping patients. So whenever we take even a feedback, whether your physiotherapist is guiding you, is patient education given to you, correct exercises, all this can be audited by feedback or some mechanism. So all this guides us into more research question. So this helps us in taking up a research to explore, to describe, or to give an intervention and find out how this intervention helps. So we do research for various purposes. So these three are the new broader purposes for doing any research, right? So which type or research method we are going to choose, that depends on what we are asking for. If we are asking that what the person's perception about it, what the person's experience going through the low back pain or a spinal cord injury is, or what a person's or a caregiver's attitude in treating certain patients of cancer. So when we want to know what is the meaning to the patient or to the caregivers, and we have questioned why this has happened, how this has happened, what impact it has on lives. So for all this, the research method we can implement is a qualitative method. For other, where we have numerical data or putting forth, like if we take the pain, we do put it as a visual analog scale. So even putting that, it is still a numerical scale we put on. The outcome measure scales also we put as a numerical scale. So that may be a non-parametric, but it is a data in figures. So for all that, we choose the quantitative research methods. For any research, we have the first thing, that is the ethics. Okay, we must never forget whenever we are asking any question and we are undertaking the patients into confidence or the students or any clients, we have to consider all this. So though for any research method, it is applicable, though we are doing qualitative, quantitative, or a mix, that the consent, confidentiality, protecting all these documents, not sharing it, it's a vital. Also, we must say that, and we must ensure that there should not be any physical harm which is being deliberately being given. So that is there. So doing some good is very, very important, and being fair and equal. So there has to be justice in taking up the participants. So all these ethical considerations are vital whenever we think about the research. So as we said, depends on our question which methods are available to us. So broadly for physiotherapists, it's the qualitative research method or quantitative research method. These days, if it's a larger scale and a big unit, more people undertaking, we can have a mixed methods, which adds more value, the meaning. So both the things can be there triangulated, which adds, but it's a big topic. We are not going to enter into the mixed methods today. It is an overview of qualitative and quantitative. In both of it, there are specific designs depending on what we are looking at. In qualitative, it's the phenomenological research, grounded theory, ethnographic, or a narrative. There are more forms of qualitative, but these are the basic things which can be applied by physiotherapists. In quantitative, we have experimental and descriptive, where observation is done with associated based or association based or a descriptive. It's observation and the experimental. So in quantitative, we have more subgroups of each of it. So we will go through the qualitative studies first. Qualitative studies or a method investigate into the areas if we are looking at interpersonal interactions, professional socialization, if physiotherapists are mingling, what is meaning to it, having a party, why they are going for a party. There are so many things can be asked. So whenever any conference is taken, it's a professional socialization. So you can look at it. Why do you come for a conference? What do you gain from it? What do you think? So attributes and values held by therapists and patients. All this, if we have these questions about patient compliance or teaching and learning, influence of environmental factors on our mind and body, or we have to have a clinical decision making in a newer concepts, including any of all of them. So if we have a question like, how do children and adults interpret healthy eating in India? Or what factors influence employee retention in a large organization? Or how can teachers integrate social issues into social health science curriculums? So there are so many things which can be addressed by using a qualitative method. So why do patients not do exercises or not follow do's and don'ts? Why there is non-compliance? Just giving them a questionnaire, we may not understand. So if we have an in-depth interview and follow them up, take them into confidence, ask them 2-3 more times, visit them, we will understand the better concept. So that's where the qualitative study designs are going to help us. What are the expectations of postgraduate students from certain course? So we can have an in-depth interviews with, and for all that, we will use the qualitative methods. So what are the various theoretical perspectives? It is called as a perspective rather than a design in qualitative methods. So ethnography, it is that the researchers immerse themselves in the group or organization and understand their experiences. It's not this one time and follow, just mingle with them, ask a few questions and interview and leave. No, it's ethnography. Then there is a phenomenology, where a phenomenon, an event or a problem or any disease has been there experienced by the person, how the person is living with all those experiences. So for that, there is this perspective, theoretical perspective. There is one more, grounded theory, where there is a vague idea about what it can be. So there is a large collection of data on the topic of interest and a theory is developed through this grounded research. And then there is a narrative. So if we cannot point out to one of it, we can just say that we are going to do a narrative qualitative study. We may not be able to identify that this is ethnography or phenomenology. That can also happen. So for that, the newer terminology has come as a narrative research. We can take the help of this perspective as well. So we'll go through each of it a little bit briefly. So this ethnography has a background in anthropology. It means portrait of people. Now it used to be that tribal or ethnic groups, so that is ethnography name has come from it. But today, as a physiotherapist, we consider ethnography can be a professional group. So a group of physiotherapists or undergraduate students, postgraduate students, or a particular patients, all that can be considered as a portrait of people. So ethnography doesn't mean only about tribal or ethnic background. It has more perspectives added to it as such. Okay. So we'll have two examples where we will understand this, because here the researcher examines and observes these patterns, behavior, customs, the way of life, how they mingle socially, what are their patterns, and it involves prolonged observation of the group. So actually the researcher also can become a participant of the study. So there is a lot of bias. So it's slightly different than the quantitative. In quantitative, we don't want the researcher bias to be there. We want everything to be cause and effect, or it is, we want to find out correlation. We don't want our bias or the researcher's bias into it. Whereas in ethnography, it's actually the researcher can become a participant to gain the confidence and know the insight of people. So this, and that's why it's a bit different to undertake a qualitative research. So the person who is actually undertaking it should be well qualified, should know, should be able to handle patients or people's responses, because at times there can be nervous breakdown if we are going to ask them few questions. So we should be able to handle all this very carefully, especially when it comes to patients. Okay, so a very good example I came across, a study by Dr. Khatri et al., the ethnic diversity pertaining to physiotherapy education in Sweden and India. And a team of teachers visited a Sweden college institute, and they stayed there for a few weeks more time. So this aim was to investigate the culture of physiotherapy students and teachers, and to have a comprehensive understanding of how the education is imparted into that area of our globe. So it was quite interesting, and they collected this data, they mingled, they stayed, they interacted with so much. And of course, the conclusions are very big, but they've just put it that physiotherapy education in Sweden is different. It's different culture altogether. And there is a focus on student-centered approach. Students have to bring in their own expertise and have to strive hard. Their beliefs are also slightly different. That active physiotherapy intervention, they thought was much better than doing something passive. So there are so many theories, points have been emerged, And that was a great experience by them to, share this and publish the data. So we understand that what different perspectives, different countries, cultures have. One more study was done by Yarborough in UK, and she continued to interview students, clinicians, and the doctors, and all the academicians. And they developed the curriculum and reformed it through this interaction and ethnographic study. So this helped in development of the new program, because we need to have good physiotherapy academic curriculum in order to cope up with the newer developments. Because if our curriculum is not developed accordingly and the new emerging disease, then we are going to lag. So we are teaching something age old, which is not going to help. So for all this, a qualitative study can work and help us. One more interesting perspective is of phenomenology. So phenomenon is a situation, it happens, and it could be a disaster, or it could be some illness, or it could be many things. So it's called as a phenomenon which has happened. So even a knee replacement surgery is considered as a phenomenon, or having a diagnosis of RA or OA is a phenomenon. So this overlap is there between, phenomenology and ethnography, because if the people having OA will be an ethnographic group, but having to live with OA, again, it's a phenomenon. So there is a lot of overlap in qualitative perspectives. So we have to understand that this is allowed. So a person can say, I'm doing a phenomenology report to say about the experiences about people living with certain problem. Okay. Or it could be there was a disaster happened, people had this earthquake or floods, and there was so much of a disaster happening, building collapse. So what happened to them? Accidents, so much of a psychological trauma. So all that can be studied by using the phenomenology perspective. So this all started in philosophy and psychology. All this qualitative research has emerged from different specialties, and they give the name accordingly. So this focused on understanding the lived experiences of individuals who have undergone some phenomenon. Now, if we have a figure of 9, one perspective will be, he will feel it's 6, another will feel he's 9. So the perspective of something will be different for different people. And we must understand both of them are correct in their own ways. So we must understand this, and we can make them aware by different things and asking their opinions again and again. So that's going to work. So there are many examples of this, that in respect to lived experiences of carers of cerebral ataxia, how mothers are undergoing through this experience of treating or living with children. Or it was an insight from physiotherapists' lived experiences of patients treating OA. So this person is expert in treating OA, and they have taken the perspective that what can be done? What is the psychology behind just this simple osteoarthritis? So something like that also can be explored for. So no question is also small or big. It depends on what we are looking at and what we are finding at. One more thing, I feel it's more difficult area, the grounded theory. So we don't know the research question at all, but we have something vague thing that, oh, I want to find out what this is and come up and make a hypothesis out of it. And then that can be tested by using a quantitative measure. So then they say we will have both approaches. So at the outset, it's not known yet that what's going to be the findings. This was developed and rooted in sociology, and it started development in 1960s. So in sociology, we find a lot of grounded research because the idea is not known. The theory is constructed from the data who have experienced the phenomenon under study. With 1 or 2 examples, we can understand this better. So Kate Grafton did a study. There were many Indian physiotherapists traveling overseas and especially to UK. So she wanted to find and explore why physiotherapists travel to UK. So she took several interviews in order to know, because once they travel and come to certain universities or seeking up jobs, then they have to do a quantitative study also. So in order to know that, these things emerged, that they came for professional development or adding knowledge and skills or a varied experience of different cultures, and they aspired for professional autonomy, which was there more into UK according to the participants. But all of them also said into that, who were taken into this perspective, that they plan to return to India once their travel objectives were met. So that was also an interesting finding in this study. So now all this, the uniqueness, always qualitative studies can be unique. It may not be able to apply to others. Whereas quantitative, when we say we will give these exercises to these type of patients, it can be applied to others also. So we cannot generalize this statement to others. So, but we can get so much knowledge by doing such a qualitative study. So from this, they started developing that might be that what can be there to retain them, or when they come back, it can be further what they gain, whether they bring it back to India, what are they doing for? So that aim and objective, whether they have made, have to be followed through. But all these things emerged, and she said this was a grounded research. There was one more grounded research done in 2005 in order to check that what is this patient's satisfaction with quality of hospital care. So it was undertaken. So they checked with food, medical care, nursing care, room, diagnosis, treatment, physiotherapist, doctors, nurses, everything. And there were many things which they realized, right from keeping up good room, hygiene, all this. Food was also very important part when they served that. So patient satisfaction depended on so many areas, and then they could do a quantitative study. So this planning and strategy for health service could be arranged by the hypothesis we developed from this grounded theory. So when we come down to the narrative, which is again can encompass any of these three. So we have narrative qualitative designs. There are many such studies now undertaken in the COVID pandemic. There are a few more, this new one, qualitative inductive content analysis of nursing students' perception experiences during the COVID situation. Because everything cannot be just throwing one questionnaire and getting it back. It's not so easy. Qualitative method for determining student satisfaction with teaching quality. So students were interviewed many times to understand that what teachers are lacking, what is the best, what they would like, and so on and so forth. I like this one, a qualitative study of middle school students' perception of unstructured time. I feel as a student, sometimes goes unstructured, sometimes the teachers don't come, so 1 hour. So what is their perspective of this unstructured time and how they share this time and what they do into that time? So we can have any of such study design where we can have the qualitative design to understand the meaning, to understand the perception, to know the experiences and satisfaction or not dissatisfaction, any of these things. So to study this, the data and the collection is slightly different. It can be a focus group discussion first, small in-depth interviews, observation as a direct observer, or keeping diaries, role play, self-administered, semi-structured questions, and recorded analysis. So it could be audio, video recordings. Of course, we all need a consent from the participants. So various methods of data collection are there. And the analysis is slightly different, that there is a coding done rather than giving the numerical thing. There is a coding and the new and ideas are there, a new code is given to it. From there, the conclusions are drawn and validation is done by asking a different questions which would lead to similar answers. So it's quite a different thing, approach to analyze these findings. So it is analytical induction, constant comparison. So I feel less studies are undertaken of qualitative because we must understand the nature of how to analyze this data. At any time, whenever we are going to undertake a research, we cannot just start with a study design and think that's it. We need to know how are we going to analyze the data, because later on, if that data is not sufficient, then we won't have any adequate results. Hence, in order, if we are going to think about doing any project, think about how we are going to analyze this. That's why I just put this slide. that there are softwares now available to study all these narratives and conversation analysis and content analysis. So it's quite a stringent thing to look at the qualitative studies, and analysis is quite different here. So if we are going to consider this, always go ahead first to see whether all these facilities, whether we will be able to do it, do a small pilot, and then think about taking large projects. Okay, so now a new way, because maybe we are not able to go and immerse and stay with people. So I feel going online is a new way forwards. So maybe even if we are not able to reach, but online, it's a new way to do both quantitative as well as qualitative. So how to check the outcomes is a challenge, but at least we can check whether they are doing it correct, so compliance can improve. So we have this new online, which is, I feel, a boon these days. So we'll go through the quantitative study methods as an overview of the study designs of the quantitative. This also is these days done online in certain formats. So we have here basic observational or interventional in quantitative research methods. So the study designs come under observational and intervention. In observation, we have descriptive or analytical. Analytical can be case control, cohort, reliability, validity, normatives, data, association, which is correlation, or a cross-sectional prevalence. Now, there are different perspectives again, whether reliability, validity, some talk it as descriptive cross-sectional. So there is an overlap between the study designs as such, and different books put it differently. But whenever we are describing only, then we can consider case study, case series. Some consider this cross-sectional prevalence also is descriptive. So there is a lot of overlap. So don't get bogged down with, even if you write that this is an observational cross-sectional study, that is okay. Any of these terminologies can be used. Okay, we'll go through each in brief so we can check what this is. Now, we also know that case reports and case series in the order of evidence comes a little bit down, that level of evidence. But nevertheless, it's very, very important to do these findings of a case, which can be a very unique and identification of newer problems, which the knowledge was not there earlier. So by putting forth such a case and having a new conception, because we cannot undertake a randomized control trial taking something new. So we can work on some patients where a normal traditional things have not worked, and we can have a combined newer approach. But we must also publish this as a data whenever a case, and if we have some few similar, then we are going to have a case series. So these observations are really important, and a uniqueness is there. As we know in medical profession, when the first case of COVID was observed, it was reported. Now, social media is also an important fact. So yes, of course, we have online publications, but social media coverage is also very vital. So take help of that as well, along with the publication. So wider people will get to know about the research. So disseminating research is very important, identifying new technique. So all the more, it's also very important. The good part of case study, case series is we may not require the ethical committee consideration for that prior. So it's allowed, because that's a problem with many clinicians. So I feel clinicians can collaborate with an institution and have a collaborative research to overcome this. Currently in India, DGCI doesn't give approvals for individuals to have ethical consideration. That's why collaboration would be needed. Going to next are the analytical studies, where no intervention is given. So when we say observational study, no intervention as such is given. But an analysis in details is done, having the case. So the similar group, that there are 50 followers, suppose, and 50 non-followers, which are same, like age match or sex match. So what is the difference between them? And we can follow up, and we would know that what is the difference when they have this disorder. So case control is a good way. Without intervention, we can do a lot of analysis in that. We have various other tools for analytical cross-sectional, which is reliability, intra-rater and intra-rater reliability study. So if I am using a tool and you're any tool, I would like to establish that if I'm using it n number of times at one time, I'm getting a similar reading. So to establish my rater, I'm using it now and in 2 minutes again on the same patients, whether it is giving similar results. Or different raters, different people doing it are getting the similar finding. So reliability is a tool, whether if we measure it, it gives the similar finding. It has got R value, P value, there are the statistical things, but the tools which we are using should be reliable and these instruments should be valid. So there is another analytical study where the validity of the instruments or the scales have to be done. So if we undertake any and we are developing any scales, that has to be valid. One more thing is again about the validity is that doing a change of language. So if we want to develop any scale into the language, so even that needs to be validated by. So it's itself a research of validating an outcome scale in a different language or for a different cultural perspective. So like WOMAC is now being undertaken for Indian perspective, where going in an auto or getting in and out of bath. So such questions are not so valid for our population. Our population may not understand what getting in and out of bath is. So the CRD Pune has undertaken and they have done it for our own population, of the Asian population. So such things also can be undertaken and we do a validity of such scales, instruments, or we develop our own. So all this comes under analytical, cross-sectional or observational. Okay. The next and very important are the cohort studies in observational studies. They are considered as not so high because I think doing the cohort itself is a big project. So here is a group of individuals who are followed together over a period of time. So to able to establish the temporal sequence of the exposure to the risk factors and development of a particular outcome. That's what the cohort talks about. So there can be newer examples also. I would say, I don't know, if long distance runners, I don't know whether they will be having OA, not OA. So if we follow them up from now, young people, right? And follow them up in 5 years, 10 years, 20 years, 30 years, what happens to them? Then only we'll be able to say whether something has happened, whether it is due to this running or it has happened due to something else. So we have a lot of things we can do for that. There are two types. So taking them now and following up them for 20 years, 30 years is very difficult, isn't it? If we find pregnant women and we see that the delivery was, very hard, they had so many problems. So whether they have at risk of developing some certain problems later on in life related to pelvic floor. Now we have to follow them up. So we have to follow them up from the age of 25 to 45, 50, 60 to know exactly whether this has caused it. So that's a big problem because we are going to lose, we may not be there. So we need to have a big setup to do such cohort studies, and they have been studies especially on the problems. So like when the study was done on smoking, the smokers, and they were followed up. So when the smokers started developing this disease after how many, packs of so many years, then there was a problem with all the follow-ups, and then at the most, then they developed the disease. So initially there was no COPD, there was no other risk. But then when they developed the risk and when they developed the disease, all that. So there are two things. Retrospective, that we ask the smokers that, okay, now you have this COPD and you have developed this disease. since when you started smoking, when you first came up with the chest complications. So all this, there has to be a medical record, or the person has to give us the accurate memory. So these two things have to be completely there in order to complete this retrospective analysis. So this retrospective is handy because we don't have to wait further for years together, but we should have the records and we should have people giving us the exact report. So it can be a retrospective, talking about what the history was, who have now come up with the pelvic floor problem, when you had delivered, when you first noticed this problem, how it developed, when it developed, whether it was after the menopause. So all this retrospectively we can analyze. But it may not give us the clear picture. So from this cohort, especially with this perspective, we can check the incidence, because now we are going to follow them up. So we understand that when this incidence and the newer cases are emerging, by doing one time, we will not be able to find out the incidence. So if we are going to say we want to find out the incidence and prevalence of something, then we have to have a cross-sectional and follow them up over a period of time. Then we will understand that within this year, there were 100 newer cases reported about this problem. So that tells us about the incidence. Prevalence, it already exists. So when we do a prospective cohort, we can analyze when that incidence has occurred. So it's very, very important. But as I said, it's expensive, time consuming over the period of years, and loss to follow up is the biggest thing. But there can be a good establishments and big institutes do take up this prospective cohort. Just having a follow-up for 1 month, 2 months, 1 year is not talked as a cohort. Okay, it has to be a long-term follow-up with a group of people. Then only we say it's a cohort. Coming up to the correlation study, there are two variables which have a relationship. So we can describe and predict this relationship amongst the different variables in an individual. Okay, so relationship of forward head posture and the core strength. Is there any relationship? So we can have this. We are not manipulating any of the variables. There is no cause and effect being. We cannot say this is causing that. For that, we need to do an intervention and give a core muscle strengthening and see whether that forward head posture is now going to change. But to know this, if we observe that there is certain relationship, we can first take a correlation study and then further give an intervention and further then say that this was cause and effect. So correlation doesn't talk about any cause and effect. They are just coexisting together. If we have a larger sample, we can say that they are associated. So that predictive value will come if we have a larger sample size and the analysis will be slightly different. So if we say association, then it also gives some prediction. If you are saying only correlation, then we analyze it differently. So whenever you are thinking about a question, think about what is needed, what is the data analysis which is needed, then that will take us further. Okay? Just stopping at knowing the research method is or the study design is not sufficient, because analysis will be different for different study designs. So relationship between 6-minute walk distance and VO2 max in COPD patient. Whether this causes this does not state. It only states the relationship or relationship between body weight and the peak floor and extensor torque using isokinetic dynamometer. So all such things can be undertaken, which is also important to know that whether these two things coexist. Okay. Also, we can have a normative studies. There are so many different characteristics of different people, races, age, gender. So we can have so many normative studies done, especially when there are newer tools developed. We can establish a standard, because all this nerve conduction velocity, we know the normative values because somebody has done it already. So we know that, yes, this is what for upper limb, lower limb, this is what the nerve conduction velocity is, or this is what the range of the joint. So somebody has done this normative studies. So that can be reformed, redeveloped, like lung chest expansion. So some of them are doing that at different age populations. So what is the normative? We must know in order to understand whether there is a problem. Okay. So it's also an observation study, the normative studies. Okay. Cross-sectional and observation. Lot of students we also undertake by sending up a research questionnaire. So this questionnaire and a small maybe assessment helps us understanding the prevalence and what are the associated problems with it. So whether the auto rickshaw drivers have a prevalence of low back pain or where they have the pain, all this can be defined. Then we can think about giving the intervention and causing it. So we can cross-section, we can understand the problems and prevalence in a larger sample size. Of course, there is a controlling so many variables becomes a problem, but it's understood that when we are undertaking, though we try to say that we will take only these people, and we will be then able to generalize that results to only those people. We cannot generalize anything to anybody. So if we are taking certain population, like we say urban, rural, all those things are different. So we define this population and then we identify the prevalence into that population. Okay. Then comes the experimental study designs, the most studied. In experiment, or it is also called an intervention. So intervention means we are giving some treatment or even giving the patient education is also a form of treatment. So we are deliberately giving something to these patients. Amongst highest are the randomized control trials, or then it could be a comparison between two. We are giving an intervention. Some call it as observation because if we are not changing, then that's only observing the effects of two different interventions. So there is a small difference between a randomized control trial and just to do a comparative study between two different modalities or any exercise techniques. Okay, repeated measures design, crossover, and quasi-experimental. We'll go into a little bit. So when we say we are going to do an experiment and randomized control trial, we have to set up something which is different. Otherwise, it becomes just an intervention. Okay. So we are doing this, we are experimenting. That means you change something to call it as a randomized control trial. Same exact something should not be there available in the literature. So if we are using tens and we are giving certain frequency, then change it or actually increase the time duration, do something different than the conventionally what it is given. Okay. So whatever is given conventionally can become the control group, and what is being changed, that's called as an experimental group. And then there is a hypothesis. Hypothesis means the researcher would think that this would work better than the other. So at the outset, we have a hypothesis here as against the qualitative. So the researcher thinks, I feel yes, it will be acupuncture like TENS would work much better than conventional TENS. So that if that is my hypothesis, I would study it by using a particular modality. So I have this hypothesis and I am trying to test it. So I have null hypothesis and I would like, then we reject that null hypothesis and accept that hypothesis. Okay, we cannot prove anything by doing some small sample. We say I have proved this, I have proved. We can't prove. We just reject this null hypothesis and accept that whatever we felt was correct. So in this experimental or the randomized control trial, we have variables which are intervention group is the independent. Then there are dependent where we check the outcome measures, and then there are other variables which we are going to control. Okay, so there is manipulation of these variables, and predetermined experimental condition is given to at least one group, and other group forms the control. So if we are giving electrical stimulation for muscle strength, we must consider so many factors there. So we have to check that the assignment is random so that every subject has to a group. Okay, and bias should not be there in the randomized control trial. So that's the most important part, and hence blinding is needed in having a randomized control trial. At least somebody else should check the outcome measures if the researcher is going to give the intervention. So the person who does the outcome doesn't know which group this person began. So that gives the validity to this study much more, because the researcher would want to go with his or her own hypothesis. Quasi-experimental is another study design where the randomization, if it is not possible, or there is no comparator group. So if we have something new coming up, we can just do on a small, and or it is not feasible to have a control group. At times that is possible, that control group may not be there. So first I would like to establish that this works, and if it is safe, would be using only pre-post. So it's also called as a pre-post or a quasi-experimental study design. Second comes into the experiment is the repeated measures. So one group giving all the conditions is followed up at 1 week, 2 weeks, 4 weeks, 8 weeks. And how they progress can be checked, that within first 2 weeks was the better results, range improved in how many weeks, muscle strength improved in how many weeks, because different outcomes can change over a period of different times. Because what we do is use 4 or 5 outcomes and we check at end of 4 weeks. So if we have repeated measures, we will understand that, okay, pain improved within this first set. This improved within so much of a time. So then whenever we are going to set the protocols, we can set accordingly the short-term, long-term goals. So it's very important that this repeated measure study design also helps us in knowing which outcome measures help where. There's one more also, which is called as a crossover, where both the therapies or it is given to the group. So A is given first and then it is interchanged. Or one of my students also did music while the treadmill walking to set the parameters, walking with a particular music, not walking with the music. So what changed? So one group did first without the music, then they did with the music. So they did with and without the music. So it was a crossover. So there are 2-3 different type of crossovers. A, B can be done. So the participants serve as their own controls. So there is no internal problem because different people behave differently. They have internal problem, external problems. So all that can be also controlled. So we have this quantitative research design. Are we going to give any exposure or intervention? Then it is experimental study or intervention study. If it is only observation, is there any comparison group? If no, it's only describing. If there is a comparator group, there is a case control or a cross-section or a cohort. If experimental is random allocation is there and a newer therapy is there, it will be randomized control trial. If it's not there, then it is only a comparative study design. Okay. So there are strengths and weaknesses of both the qualitative and quantitative researchers as going through this study designs, because they are mutually actually helping each other. So giving this meaning to whatever the quantities we are getting into by doing a lot of statistics, p-values, and so many values, mean, mode, median, and things, we also have this meaning. So we can undertake any of this understanding our own self and the needs of what we are looking at. So identify the research question, identify the need, look at which research method will be applicable to our question. If we have a larger team, can we have the both perspective and use the mixed picture? And then can we analyze further? Okay. So going through the attributes of the quantitative and the qualitative studies, the goal of the quantitative research is we have a hypothesis, we have a prediction that what could be the outcome, and we test it at the most. So if we think that this must be the prevalence, possibly, is it there? Or you want to find out. So there is some prediction that this is the prevalence of the problem, that teachers, school teachers having the shoulder pain. So we have a hypothesis that something like that is there. So we would like to have this prevalence being tested. Whereas quantitative, there is no hypothesis. We understand and we see the meaning. So we do it to understand the problem, analyze and see the meaning. The data collection in the quantitative is in the scale or number. giving the number to the visual analog scale, it is still an data. Okay, it's non-parametric and the analysis will be different, but still it is a data and number and a scale is given to it. Whereas the data collection is all observations, it is the video analysis, it is the audio analysis, it is looking at the posture, looking at even the facial expressions. So all these observations, even they had done a study on, gait analysis, looking at the face. Do we look at how the patient is walking? Do we see the facial expressions of the patient and know that? So something like that also has been undertaken, a lot of complex studies. Okay. Design is very structured, has to be structured at the outset in a quantitative studies. We cannot deviate. So if we are going to deviate from our protocol, we have to go to the ethical committee saying this was the problem. Okay. Whereas it's a flexibility, everything is there in qualitative, has to be flexible. Only then only we'll understand the problem of the patient. The sampling is random and representative of the population. Whereas qualitative, it will be selective and purposeful. It will be snowball. So we select those population under study. Generalization can be done with the quantitative studies. And a similar patients, we expect that the similar results will be there by giving certain therapy. So we can generalize this effect, saying if we have studied people between 40 to 60 of a particular disease, we can generalize that what our study results were, the same can be expected giving to those others. So this generalization is possible in doing a quantitative, whereas it's unique in a qualitative. As I said, the descriptive, those people who had gone there were only asked. So it may not be that the next group set will be giving the same answers. So we cannot generalize this, but we can draw some inferences from it. So analysis is very deductive. We come to p-values and things like that. Whereas in qualitative is inductive and developing the theory. Okay. Role of the researcher is completely detached and no bias should be there in a quantitative study, not even trying to manipulate anything. So it should not be there. So bias has to be removed and it should not be there. So understanding this bias is a big problem. So quantitative, the research is totally detached. Whereas in qualitative, the researcher can be a participant, as I explained. So it's completely immersed. So to gain the people's confidence so that they are going to share. Nobody is going to share their vital information just like that when we say hi, hello. So we may not understand what their meaning and experience is. So it looks at completely a different way what we are looking at using these research methods. We require quantitative studies, definitely, but we also require to know the meaning and things. So we require this qualitative method to be implemented for, and it takes a lot of discipline to take up this research, and we have to have the time. We cannot just hurry up doing things. So we really have to think about even the fundings and things. So there are so many things involved in research, and hence we must think in toto what it will be. So follow up the whole procedure. When we have a question we have identified, check literature, what is available, choose appropriate method and study design, think about analysis and publish. So when we publish, we understand the limitation and what could be the further scope would lead to further research questions. So this goes on, and we can develop ourselves and to the best of for our patients. So thank you again. So if there are any questions, so I feel
yes, ma'am, that was really, really insightful. I'm sure there was so much knowledge there for all of us to absorb, especially the younger students for whom many of the words must have been for the first time. Ma'am, I'll just come to a very basic question, is that you did mention that once students do their projects in final year internship, and later obviously MPTs do their dissertations, how can we inculcate the idea of publication among students at a younger age group, like say the third year, fourth year interns? Like I'm sure all the academicians work at that. We used to work at that when I was a part in academics. But how do we inculcate the idea of getting the research topic with a view or a mindset of a publication? Like how can that be?
Yes, it's very important, because if we leave it without publishing, then whatever done, nobody will know. So that research has no value. That's why I'm saying it's a very valuable research and we need to publish. So if I feel as a UG student, the guide, they should choose a guide because they may not be able to know, but the ideas come from young people.
Right.
Yeah.
Now ideas I have lost, or my ideas can be age old. So whatever the new generation is facing, I may not be able to understand. I will just think that, oh, they are thinking this way, but their perspective can be something very, very different. So if I undertake a research from their perspective, cannot be possible. So always I would take help for the younger people, but they need our guidance. So I would say that for a young people, we will say you have a guide. And guide will help you in getting this disseminated as a publication. Because even if they do, efforts will go in vain. So the whole process is not completed. So I think that UG students should be guided for, and guide is there to help them in getting the publication.
Yes, ma'am.
And we have to say we will give you some funds or we will give you some scholarship, but if you publish, that's
exactly
given after the publication.
Exactly. Yes, ma'am.
Okay. So, ma'am, even I have a...
Many universities also fund the undergraduate research.
Yeah.
That is also there. Yeah.
So, ma'am, even I have a very beginner level question that what do you think, how long can we actually wait for the, a proper sample size, like that there has to be certain number of people included in the research, only then can we collect the data. So, like, what do you think, how much time does that actually take to gather that number of people?
So for that, suppose we have to see, and it is well accepted. Suppose we have an OPD of, suppose 100 patients coming to us, and out of that per day. So out of that, in 1 month, we get so many new cases of arthritis shoulder. So I know, right, that in 6 months, how many periarthritis shoulders come to me.
Okay.
I'll get an idea of that. Okay. Out of that, with inclusion exclusion, will come to less because everybody may not be there that we can take. And it's well established that if we say patients coming to us between these 6 months were recruited. So that is the thing we first need to know. And hence the hospital records are very important. Then only I will get to know. I know I get to back pain patients 5 every day. So in a week, at least I will get 20 patients.
Yeah.
So I would know that out of that, maybe follow-up will be lost to follow-up. So the best guide is to know and understand how many come to us in 1 month or 6 months. Keep that time. That will help.
Right. Thank you.
Now, a very common question which many of the students definitely, or the younger ones whom I have been interacting of late because of PhysioEd, how has COVID and the virtual world changed the situation in which research has been, the world is going on? Because I know we are out of lockdown and we are getting back to postings and everything's getting normalized, but obviously things are not what they were like pre-COVID. So how is the field of research, or like how much impact do you see COVID, or because we don't know how long this is going to go on? So like how will research be impacted?
Of course, I feel we have got a newer tools. Of course, we cannot replace the person coming here and checking the outcome by ourselves by using a goniometer on them or the strength measurements or anything. But there are many newer tools developed to see the range, to give this self-questionnaire to patients, to guide them over. Now, see, everybody's got the net connectivity. Most of them, I would say, we can have their video. They are doing online interventions also.
Yeah.
And some people are liking it. So they need not visit every time. We give them, share their own exercise videos. So, and we can follow. So we give them a specific time and time. So I feel research is now undertaken online. That's what I'm trying to say. Of course, very complicated cases, we may not be able to, but we say that we are doing a tele-rehab. So the research is also now a way ahead forwards.
Yes, ma'am.
So they might need to come lesser number of times.
Yeah.
So exact, if we want to measure something exact by handle dynamometer, muscle strength, then we can call them at 12 weeks or something. In
Right.
that, while other outcome measures can be checked.
Checked. Yeah. Yeah.
So we
Right.
have newer avenues which are there. Of
Yeah.
course, COVID has a problem, but it has another newer solutions for development of our practice. It's globalization, we never thought we will do
Yeah.
like this.
Yeah. Many online platforms have been created because of COVID.
I feel the amount of education has been disseminated is much more, and access
More.
to all that is much more. I believe so.
Yes, ma'am.
Research is challenged, but we can
Yeah.
take a consent online through
Yeah.
various things. So we still have to. We don't know whether it is equated or equal same as how in person it will be.
Yeah.
At least it will save some of the visits. That much
Exactly.
capture.
Yes, ma'am. Thank you,
Right.
ma'am.
So I feel we are just on time, right?
Yes, ma'am.
Right.
Yeah.
Also, ma'am, if you allow,
Yeah.
I could just talk about an upcoming webinar that the resource person is Sir himself.
Yeah.
And it is basically a roadmap to Australian education and how a physiotherapist from India can move to Australia.
Thanks.
So that sir is going to do really soon, and the registrations are still open. So I just thought, this is a good platform to let more people know about it. Since this is a very repeatedly asked question, that how should one move to Australia or another country?
Yeah, what has been, how the registration there,
Right.
many things are different. Yeah, we
Yes.
Yes, ma'am.
like to explore the world. I feel we should explore the world and
Yes,
people
ma'am.
guide
Definitely.
it properly. So
Yeah.
is very important. Otherwise, there are
Yeah.
too many advertisements and not too.
Yeah. Exactly.
So
Yes, ma'am.
guidance is going to help all this.
Yeah.
Right.
I just want to add a point is like all of us are aware that I think the Indian education is one of the best, no doubt, by leaps and bounds. And the biggest asset which we have is a population. So when I talk in terms of research, the sample size and the amount of opportunity which we have, like I've been to a few unis, just checked out how things are done here. And the main issue is the sample size. They don't have enough samples to have for the research publications. So Indian students and Indian education system is the major at a advantage. What we can say is because we have an opportunity to conduct research. So it's just an appeal to each and every student who is in part of some way or the other to have some research being done, because you'll never get that opportunity once you move out of India. It's very hard.
Yes, some universities also just submit the synopsis and things like that, the research area. So
Yes, ma'am.
best our students here, and definitely undergraduate program is good, but we back into some infrastructure.
Yep, definitely.
With globalization, we can bring in, the funding
Yes.
for the basic problem.
Yes, ma'am.
Doing a bigger research project. So if
Yes,
I
ma'am.
would like to do something for osteoporosis, should have a DEXA.
Yeah.
DEXA that funding and give them some
Funding.
months
Yeah.
on the DEXA.
Yeah.
That's the problem here,
Yes, ma'am. This is a boon and a bane both sides.
Okay. I feel whatever the small thing, as I said, do an audit, do a small step, and that's why collaboration is a big
Yes,
thing.
ma'am. Yes, ma'am.
At least we make
Right.
of the population,
Yeah.
and we can have tools which can be simple also.
Simple. Yes,
Right.
ma'am.
Even simple tools can give us good results. Of course, if the gate lab analysis is there, it cannot be replaced.
Yeah. Yeah.
Right.
Yeah. I think
Okay.
at least some ideas and perspectives it can. So
Yes, ma'am.
can mail me anytime.
Yes, ma'am, definitely.
Definitely.
We would obviously first I would give a word of thanks, and obviously Harshita will take over after that. We would be highly thankful to Dr. Nilima Bedekar ma'am to come ahead with this idea in which we could have this platform shared with Physio TV, Ortho TV, Sancheti Institutes, which is one of the leading institutes in India in physiotherapy, and at PhysioEd, which we are in our infancy, and it was an immense pleasure to have ma'am. Irrespective of, despite the fact that she's not been keeping well, ma'am went ahead with this. So that shows the professionalism which ma'am has. And I would be really thankful for the session which was here, because I'm sure many of us are going to watch it later in the recording on YouTube, and it's going to give a lot of insight. I'll be obviously promoting this session a lot through PhysioEd later on also. So yes, ma'am. Yeah, thank you so much. I'll give over to Harshita just to have a word of thanks.
Thank you so much, ma'am. It was really insightful. And I think research is, as much as you talk about it, still you know only little. So I feel if any which way, whenever you are available, we could actually have a webinar and a workshop for it online if possible. And it will be actually helpful. For maybe for the beginner level students who have never done a research, I think you could actually help them out about how to go about it.
Let's see, we'll have a team approach for that.
Yes, ma'am.
Works that way.
Yes, sure, ma'am.
Yes, ma'am. Sure, ma'am.
Thank you so much, ma'am.
Thank you so much, ma'am.
Really, really good session with you.
Yes. Okay.